So our next speaker is Dr. Marc Williams, who will be discussing cracking the code, how genomics and personalized medicine impacts pediatrics. Dr. Williams is a professor and director of the Geisinger Genomic Medicine Institute. He co-leads the MyCode Community Health Initiative Sequencing Project and directs a whole genome sequencing project for children with undiagnosed disease. Dr. Williams is a member of the Scientific Advisory Board of the NIH Undiagnosed Diseases Project, and he has co-authored over 140 articles in genomics and related topics. Please join me in welcoming Dr. Marc Williams.
Thank you. Thank you very much. It's great to be here. This is my home, if you will. I practiced general pediatrics for 10 years, including 2 years as a solo practice pediatrician before I went back and did genetics. So it's great to be here with all of you. We're going to be talking about genomics and personalized medicine and how that impacts pediatrics. I wanted to let you know that I do have all these slides in a handout, so some of the things I'm not going to go into great detail on, but if you're interested in learning more, then please refer to the handout. We're going to talk about sequencing in two different settings, a medical indication and for screening. We're going to explain some differences between the return of results of variants that confer risk for pediatric versus adult onset disease, and begin to explore some of the perspectives of parents and adolescents regarding their desire to understand and receive these results. Now, the focus today is going to be on next generation sequencing, which is where rather than sequencing gene by gene by gene, we're sequencing large portions of the genome, whether it's the pharmacogenome, gene panel testing, or exome or whole genome sequencing. We're not going to consider traditional single gene tests, and for this we're only going to consider the middle three. We're also not going to talk about pharmacogenomics because they're sort of a different animal. Now, when we talk about sequencing, most sequencing is being done for an indication. We have an individual with autism spectrum disorder, or intellectual disability, or multiple congenital anomalies, and we do sequencing to try and understand why they have this condition. So if we find something, a variant that is related to the indication for testing, for example, a pathogenic variant in SCN1A in an infant with severe myoclonic epilepsy, we can make the diagnosis of Dravet syndrome. So that's a primary finding. But there are also the potential for secondary findings, or what some people call incidental findings, which are findings in a variant in a gene that is not related to the indication for testing, but has medical implications for the patient. And those are found in about 2 to 4% of exome sequences. Now, this is not really being done much in the clinic, but we're getting to a point where we might consider sequencing without a medical indication for screening, so perhaps in the context of newborn screening. And in that case, any pathogenic variant in a gene that is identified as medically important by whatever criteria is a finding. So just by show of hands, how many of you have either ordered or received the result of any genetic test on one of your patients? Yeah, at least 3/4 of you. How many of you have either ordered or received a result from a next generation sequencing test, a gene panel, an exome, or a genome? Maybe about 1/4. I was expecting a bit more than that. How many of you have received a secondary finding, a finding that was not based on the indication for testing? Actually, a fair number of you. Well, that's good. So there's at least a few of you that have had some personal experience with this. Now, the American College of Medical Genetics and Genomics in 2013 came out with a recommendation about reporting secondary or incidental findings in exome or genome sequencing. It was a pleasure to be on this group that came up with these initial findings. These have subsequently then, a version 2 of this came out last year, and this is being continually updated. So in our initial list, we had about 56 genes that are now up to 59 genes in version 2 that met some threshold for medical actionability. And the list is updated as knowledge accumulates, with some genes coming on, some genes moving off. Initially, the recommendation did not provide an opt-out for patients not wishing to learn secondary findings. However, this was modified so that now at the time of testing, the parent can make the decision to opt out of receiving secondary findings for their child. But the recommendations do recommend return of secondary findings to pediatric patients for both pediatric and adult onset conditions, which was a fairly controversial recommendation. Now, there are a couple of conditions that we talk about with medical management guidelines that do not have actionability in childhood. So hereditary breast and ovarian cancer associated with BRCA1 and 2, and Lynch syndrome, which is an inherited form of colorectal cancer, endometrial cancer, there are no actions that you would take in the pediatric age group to modify medical care other than providing information. There are also non-actionable conditions which we're currently not recommending return, so Huntington's disease, Alzheimer's disease. Now, what about returning these results to children of these adult onset conditions? There's little evidence to guide how we return genomic results for any conditions in childhood without a medical indication for sequencing. And the professional guidelines that exist for returning information on adult onset conditions are conflicting. And they're based on consensus expert opinion. And most of them are based on presumed psychological or psychosocial harms. So here are some of the competing guidelines. In 2013, the FACMG guidelines said you need to return results regardless of age when sequencing is done for clinical purposes. So not for research, but for clinical purposes. And they have been revised to suggest an all or none opt-out for secondary findings in 2014. Now, the American Academy of Pediatrics guidelines from 2013 says do not test children for adult onset disease and do not return results for an adult onset disease. And then the American Society of Human Genetics in 2015 says defer testing for adult onset until adulthood. Although both the ASHG and the AAP acknowledge that there may be reasons to test children for adult onset conditions, such as psychosocial distress and after careful deliberation. And there are pros and cons to this. You know, on the pro side, the information is powerful. It can lead to early prevention. It identifies other at-risk family members like parents, where we can perhaps avoid a significant condition, and can identify a new condition in the family. But it's also looked at as being, well, this is paternalistic. We're really taking away choice by just returning it. We're interfering with the child's autonomy. There's no medical recommendations for children, so we really can't do anything. And the parents may, in fact, treat the child differently. They may be vulnerable. So all of these proposed psychological harms are based on a handful of anecdotes, reports of harms from receiving results for adult onset conditions. And in particular, this has been highlighted in breast cancer in young girls because of sensitivity around body image. But there's been no empirical evidence to support this concern. There's been essentially no research done to say, is this really a problem or not? So the ethical dilemma here can really be divided into two issues. One is the childhood harm. Are there harms associated with returning this information as a consequence or a consequentialist argument? Well, that's a testable hypothesis. The right to an open future is more of a philosophical argument, which is, well, we're depriving them of some right, which we may or may not agree that they have. And that's really not something that we can empirically test. That's really more about a belief system. Now, we have a large-scale exome sequencing project done in the research setting at Geisinger, where we've now done exome sequencing on over 93,000 of our patients, and this is open to children. So one of the things that we did was to create a Precision Health Youth Advisory Council, because we thought it was critically important to understand how our youth actually thought about this. By the way, this is not a representative picture of the youth in central Pennsylvania. I just wanted, for any of you that are from there, you will recognize that immediately, but so just grab that off the internet. Now, this is consistent with what the World Health Organization has said we should do. Adolescent leadership and participation should be institutionalized and actively supported during the design, implementation, monitoring, and evaluation of adolescent health programs. So we're really taking that to heart, and we're trying to engage around this issue, and it's really been fun to work with our adolescents in this. So the research question that we're beginning to think about is, how should we ethically manage genomic results concerning adult onset disorders for our pediatric and adolescent MyCode participants? I'm going to talk about two early areas of research. So one is we wanted to assess the attitudes of parents towards the return of genomic information in children from a biobank and explore differences between the pediatric and adult onset conditions. And then we also wanted to explore the attitude of adolescents regarding genetic testing for adult onset conditions. So for the initial question in our design, we used a focus group methodology. We used something called deliberative engagement, which means that we provided education to the participants and followed by a structured discussion, because we would expect that most of these folks had not had any experience with this, and so to just ask them questions without any grounding would have been problematic. We used education and discussion of professional guidelines that were out there and also presented them with the ethical dilemma. And then we had a structured discussion of 2 scenarios of healthy people learning genomic health information and education about the conditions. One with immediate medical implications for children, a pediatric onset condition, and then an adult onset scenario. Our participants were adult MyCode participants with children who had enrolled in MyCode because the parents could enroll their children. We thought that there might be differences in the way parents thought about this if their children were younger versus older, so we divided them up into 2 groups. That was an arbitrary split. None of these individuals had received results as a result of the MyCode participation, because we didn't want to bias it with people who had received results versus those that had not. So this is all in the hypothetical. And all of the children were healthy. They did not have some type of a genetic disease. So we had 17 parents that participated, 3 fathers, 14 mothers. This is not atypical when we're doing research. The moms are always much more engaged. And we had a 16-year-old boy that actually attended with his dad, which was kind of a fun interaction. So we asked, why did you sign your child up for MyCode? Why did you think that this was an important thing to do? And then we asked a series of questions. How would you feel about the result? What would you want to do about the result? What do you anticipate would be the impact of this result on your child? How would you tell your child about it? And how would you want to be told about it? And how would you want this information kept in the electronic health record? So we looked at the focus groups with pediatric and adult results, and then with an adult result only. And the scenarios that we used were Marfan syndrome. And so some of you may know the story of Isaiah Austin, who on his NBA physical was identified as having Marfan syndrome and was unable to play in the NBA. There was something that was fairly similar, or fairly well known around that time. And then a scenario of a parent learning about a result and how that could impact their child. Regardless of the scenario, and this is something that I think we're seeing over and over and over again, our patients don't consider genetic information to be different from any other information that they receive. We as geneticists like to think it's exceptional, that there are exceptional things about it. And I think in the long run, by treating it as exceptional, we've created some problems. The one parent says, it's kind of like a peanut allergy, you know, everybody's got to know. I look at it as no differently as what my blood pressure was, my temperature. You may never be ready for potentially bad news, but it doesn't change what's going on in your body. So we asked about anticipated impact. Again, this is hypothetical. It said, well, we won't treat our child differently after learning the result. It might change some behaviors or activities. We might want to encourage healthy behavior. We'd also want to prepare the child for the management of risk when they reach adulthood. So breast imaging, colonoscopy, et cetera. In terms of telling the child, they said we'd have to tailor the conversation based on the child's maturity. And, you know, if there was a family history of the disorder, this would be a really good opportunity to discuss this with the child. You know, this is why grandma had breast cancer or why grandpa had colon cancer. They wanted that information in the electronic health record. Every single parent said the same thing. They expect the medical system to use this information for their child's health when they move into adulthood. If I knew it was in her file and they knew she had this predisposition, maybe they would test for something that they wouldn't test you and I for or somebody for. It would just be detected early because it was there. And if you didn't know about it and you didn't get tested, then what? So they recognized the importance that we have as stewards of this information. Now, parents did not engage in consideration of the child's loss of autonomy or rights to an open future, so this deontological argument. They said parental choice and the need to protect and concerns about the future outweighs anything related to the child's choice. And one of the parents said, I don't see where some kid is going to say, you ruined my life by getting me tested, and now I have to be watchful for stuff that might happen to me later in life, you know? I don't care if you're saving my life, darn you. I love doing focus groups. So in conclusion, the parents were interested in results for both pediatric and adult onset conditions with medical management guidelines. But the parents wanted to control when and how they told their children and to have a continuous conversation over time. So they didn't view this as sort of a one-off. And from a practice implication perspective for pediatricians, I think it's really important to know that parental thoughts and feelings may differ from the guidelines that we're expected to follow. And it's important in the program and as we think about research opportunities to learn more about this. And that engagement of parents through deliberative discussion is effective at eliciting their opinions and helping researchers and clinicians understand their perspective on these complex ethical issues. Now, the other interesting opportunity we had to study this was in 2016. Every year, the American Society of Human Genetics has a DNA Day essay contest. DNA Day is April 25th. It also happens to be my oldest daughter's birthday, which I think is pretty cool, to have a geneticist with his daughter born on DNA Day. Any rate, the question in 2016 was, adolescents should be encouraged to defer predictive or predispositional testing for adult onset conditions until adulthood because of the complexity, the potential impact of the information at formative life stages. So they had to write an essay about that. And over the course of the time, over 1,200 essays were submitted from high school students, over 1,000 from the United States. All of these were coded for student age, their sex, the disease that they chose to write about. They could choose whatever disease they wanted to write about, and their preference as to whether to defer or not defer. And so what we did in conjunction with ASHG was to collect all these essays, develop a code book, and then we worked with genetic counseling students to go through all of these essay questions and say, could we develop some themes about how adolescents are actually thinking about this? So if you look at deferring or not deferring for Alzheimer's and BRCA, which is hereditary breast and ovarian cancer, it's interesting. You can see here that adolescents are picking up on some substantial differences between actionability. More of them chose to defer testing for Alzheimer's disease, something you can't do something about, as opposed to hereditary breast and ovarian cancer, where you can do something about that. Now, we have a lot more data on this, but for the purposes of this session and the time limitations, I'm not going to go into great detail about it, but I wanted to use a couple of quotes that illustrate the differences. So a senior in high school, female, said, it's wrong for a teenager to be tested for breast cancer because the child is too young to know if this disease will even be applicable to them when they grow older. Tests will only increase stress among the family and the child. The child may not even end up with cancer. Very astute observation. The 9th grade male said, I disagree with the ASHG statement when it comes to Huntington disease. To plan for the future and decrease stress, those who are mentally fit should take a predictive test for Huntington disease. Notice that idea, mentally fit, which I think goes into some of the guideline language, which is appropriately mature, decisionally aware, et cetera. So the lessons learned here was that engaging the stakeholders most impacted by the issue is an effective way to understand their views and guide program development. Parents and children may value information over and above the concerns that could be raised, but they also have concerns about the information, and they express the need for individual choice. This should not necessarily be forced on people. And we need further research to empirically test the impact on children and families from adult onset information. And I'm happy to report that we were just funded by the National Human Genome Research Institute to do a prospective randomized trial looking at some of these decisional issues, which would be the first empiric evidence done in a rigorous prospective fashion to address these issues. So in conclusion, sequencing is rapidly emerging into pediatric practice. I think our show of hands demonstrated that. Right now, it's almost exclusively for a medical indication. We do the test because there's a reason to do the test. But genomic findings that have medical significance unrelated to the indication may be found and may be reported to you. Research is needed to inform that return of results of adult onset conditions in pediatric patients. So here's some changes you might want to think about in your practice. Anticipate secondary findings may be returned from exome or genome sequencing when you order it. So be ready that you may get some results that you weren't necessarily expecting. Parental thoughts and feelings may differ from guidelines and are important to consider in clinical care. And then identify genetic specialists, geneticists and genetic counselors who can assist with patient management. I also want to point out the clinical genome resource, the ClinGen Pediatric Actionability Working Group. We are working actively to look at genes and actionability from the pediatric perspective. So if you're interested in learning more, I would highly recommend you visit that website. Our work is just starting. I'd like to acknowledge all of our MyCode participants, our collaborators, and all of my colleagues, and on the Sarah Lawrence Genetic Counseling faculty and students for the Adolescent Attitude Survey. And if you're interested in doing more reading, here are some references that I think would be of some interest. Thank you very much.